Hello everyone, going to give a quick PowerPoint on stress fractures and bone health optimization. I'm Dr. Matt Sedgley. Thanks for joining. Feel free to watch and come back anytime. I'm going to kick off here with the fact that I have no financial disclosures, nothing that's relevant, and if you have any questions, feel free to reach out on that. We're always looking for financial disclosures, so anyone who wants to throw money our way, we welcome that. So let's begin. We have an agenda here. We're going to talk about epidemiology and pathophysiology of bone stress injuries, which is how I'm going to refer to stress fractures. We're going to talk about the high-risk stress fractures versus low-risk, how to mitigate the risk factors for these injuries, and then some site-specific treatments and how to talk about bone health optimization strategies. So just so you know, this is something that's exceptionally common. Bone stress injuries, I'm referring to this on a spectrum. Think about a normal healthy bone all the way on the left. Think about healthy broken bone all the way on the right. In the middle between a healthy bone and fractured bone is a stress fracture. And between a stress fracture and a healthy bone is going to be a bone stress injury. And we'll often grade those 1, 2, 3, 4A and 4B. Now, bone stress injuries are probably 1 out of every 10 overuse injuries you see, but in running athletes, cross country, track, soccer, even some of our lacrosse players, it's almost twice that. And we see a lot in the tibia, the navicular of the foot, and metatarsals. So pretty common. You may not be seeing it, but it's seeing you. Now this is ironic because, of course, a lot of our athletes have stronger bones than people who aren't athletes. But if we remember our histopathology, we have 2 types of cells: osteoblasts, who build bones, and osteoclasts, who chew them up. And a lot of times what occurs is over time, our athletes will get stronger bones. But there's often a mismatch in that the osteoblasts that build up a strong bone do so very slowly. And the osteoclasts, which chew up the bone and remove weaker bones, are much faster. And so if you can imagine, you start running 3 miles a day, you're going out for cross country, you're in your 2nd or 3rd week, you're doing 4 miles, 5 miles, 6 miles, you get about a month into your training, and then people get a typical shin splints. And what's happened is we have the osteoclast chewing up the bone faster than the osteoblasts are building it up. And so there's a temporary weakness, and this results in a bone stress injury. And usually with rest and progression back, these get better, and without, they can progress to microfracture, stress fracture, and then injury. So when we look at this, it's important to make a distinction in the nomenclature as we talk about stress fractures. Remember, sometimes you'll see masters athletes and they'll have a stress fracture, quote unquote, on imaging. We want to make sure that it's not an insufficiency fracture. And that's where there's a normal amount of load, but there's actually a reduced bone mineral density. So situations like this would be a masters runner or somebody who's got hip pain. You get the MRI and it shows they have a fracture of, or stress fracture of their sacrum. Well, you know, is that because they have some osteopenia, osteoporosis? If so, that's an insufficiency fracture. If you have someone who's overtraining, that might be a just plain stress fracture if it's normal bone that had an abnormal load. So critical to make that distinction. Here's a good picture of an MRI with a classic person you see they want a cortisone shot, their knee hurts, but the last shot didn't work. MRI shows an insufficiency fracture, they've got some osteopenia. We can also see these very commonly in the sacrum. Determining which stress fractures are low risk and which are high risk. I guarantee you this will be on every test you ever take in medicine, whether you're athletic training, physical therapy, sports medicine, orthopedist. And really this is critical because you have to know the difference between low risk, which generally you're going to do rest and activity modifications, as well as high risk, which because of a vascular watershed zone or because of being on the tension side of the bone, has a higher risk to complete and go on to fracture. And that's one where we're going to probably consult our orthopedist very early. We're going to manage that much more aggressively. And so, you know, the type of injury you have is going to determine the type of treatment you get. If again you have low risk, we're going to rest. We're probably going to get off of that bone, and once the pain and tenderness goes away, we'll, after a period of time, gradually reintroduce activities. And of course, we're going to ask, why did this happen, as we look for the risk factors. But if you have a high-risk fracture, we want to be very aggressive in the non-operative treatment, and we have to make sure that this isn't someone who really wouldn't just do better seeing an orthopedist. for definitive cares. When we look at why people get stress fractures, a lot of times it's overtraining. They do too much, too soon, too fast, and so you're going to want to decrease their load. Sometimes they're young adults who, for the first time, are really drinking a lot of coffee because they're going to take a lot of classes in college or university, or maybe they're exposed to alcohol more. These are not good chemicals for the bone. We want to mitigate those intake levels. And then we optimize the calcium and vitamin D. And so extrinsic risk factors are things, really when we look at it, they're outside the person and probably are pretty modifiable. Intrinsic risk factors. These are going to be things that are a little bit more difficult, not something you can change per se, but you can imagine if you have someone with celiac disease, their gluten allergy, or they have an inflammatory bowel disease, they're not going to have really the ability to absorb very well. They're hyperthyroid, or they have a excess of cortisol. These are things that you're going to want to try to identify. If you can't identify them, they're going to probably just have reoccurrence. Clearly, one of the things we always want to do is screen for what used to be called the female athletic triad. Typically starts with a low energy availability scenario, and then you go on to having the decrease of bodily functions, including the lowering of estrogen and other healthy hormones for the bones. And that will often give you menstrual irregularities. They have changed the nomenclature to be the male and female athletic triad because men who do not eat enough energy, whether intentional or not, also will lose the healthy hormones in their body like testosterone that are good for bones. I think the alternative way of referring to this is REDS these days, and that's relative energy deficiency syndrome, effectively putting yourself in a hypogonadal state, really to shut down everything because your body doesn't have enough caloric intake. And so whether it's REDS or screening for the triad, these are intrinsic risk factors I think are standard of care looking at. And then obviously biomechanical issues. How do they run? How is their core strength? How is their flexibility? I think that when we look at stress fractures, we know if you've had a fracture history, you're at risk for having another fracture. So the same if you have late menarche, lean body mass. As you look at these, basically hazard ratios for various predictors of getting another stress fracture, interestingly, tennis was one, but if we did a deep dive, the people who played tennis had done dance and gymnastics. And so as you can see here, the second line, the previous participation in dance and gymnastics may be awfully similar to previous participation in tennis. Again, we call that one out. Again, looking at intrinsic risk factors, triad, I think this is a classic publication. Dr. Drinkwater, Errol Natif, and others really who push this forward. I think that it behooves us always to ask our menstruating athletes, are they getting enough calories? Do they have an idea of how many calories they burn? You'd be surprised how many people have no idea how many calories they burn running a soccer tournament in a weekend. They've probably got to increase their calories substantially, and they're unintentionally underfueling. Again, the IOC came out really with Adam Tenforte and others, really looking at a holistic approach to describe this effect of a low energy availability state. Really affects everything, not just the bones. So let's do a little deep dive into the low risk stress fractures. That's the medial tibial stress syndrome, or the shin splint location, fibula, some of the feet, including cuneiform cuboid, and metatarsal shaft. Again, this is something that you'll see military folks doing long marches, and X-rays sometimes if you do them too early are a little bit unhelpful. They won't show it till you've repeated it in a week or two. MRIs are much more sensitive and specific, but you may not actually need it if they're tender and you want to treat without imaging. Cuneiform cuboid, these are going to be our bones of the midfoot here. These are pretty uncommon, but your X-rays will most likely be negative. On the half dozen of these I've seen this year, they're almost all found on the MRI, and you can usually get away with some weight bearing is tolerated at cam boot, and they do well in about 6 weeks' time. Low risk fracture, stress fracture. Calcaneal stress fractures, again, kind of that superior portion of the calcaneus there. Radiographs, you might be able to see this a few weeks in if they've been walking on it because of the resorption of the osteoclast. I think the bone stress injuries showed really well in the MRI, and I think it's the key thing here is to make sure it's not being confused for calcaneal apophysitis. Doing that squeeze test where you squeeze in the body of the calcaneus, they usually be positive. And again, limiting weight bearing temporarily. getting back into a boot after a few weeks. Many of these will get better. I think if they don't, you want to make sure you involve your foot and ankle orthopedist. Fibular stress fracture is usually occurring well up in that zone A, but happening slowly over time, not with a trauma. Again, x-rays will sometimes miss initially the first few weeks, but then repeating can increase the ability to see it. MRIs may not be necessary if you can actually see, like in this first picture, some callus going in. Many times you'll really only have to do a boot, but you'd be surprised that a lot of runners will continue to tell you they've had some pain if they try to return to running faster than 2 to 4 months, which seems like a long time, but it's probably because of some of the soft tissue attachments on the fibula in the area of the injury with the peroneus brevis and longus. So it lasts for a very long time for a non-high-risk stress fracture, and especially in running athletes. And the classic posterior medial tibial shaft. It's going to be that distal 2/3 posterior medial portion of the tibia. Almost universally, x-rays are negative. You can get the MRI to get a Fredrickson grade stress injury title to it. The stress fracture grades are 1, 2, 3, 4A, and 4B. The higher the grade, the longer usually it takes to get better. And so you can sometimes, with this particular injury, some of the literature out there suggests that if you got a grade 1, you're looking at like maybe 3 weeks. Grade 2 and 3, about a month. Grade 4s start to go on to a month and a half to sometimes even much longer, depending how severe it is. And that can help guide your athlete back. If you look at the high-risk stress fractures, these are ones that really probably need to be immediately made non-weight bearing. At the very least, have a consultation with one of your foot and ankle surgeons or sports orthopedist and make sure that they feel comfortable with you managing this non-operatively. And if they want to see it or get additional imaging, make sure that they're in a minimal position quickly. Patellar stress fracture is one of these. You can imagine if you have a horizontal stress fracture and you do not treat it well, you can get what you see on these pictures, which is it can turn into a patellar fracture. More often than not, you'll actually get a consult for what is actually a bipartite patella, and usually you'll see in this picture in the top left, it's usually around the 11 o'clock position. It looks like a fracture, but if you x-ray both patella, they look this way. Microtrauma is really the reason this happens. And x-rays don't really show the stress fractures too well. Again, MRI is a better test. A lot of times you'll treat this particular stress fracture with a knee and extension, have them rest, and make sure your orthopedic who's trained in sports is happy with you doing this aggressive non-operative care. It is often probably the most common reason you'll see back pain in young athletes in the teenage years, which is going to be a stress fracture of the low spine, seen here in a picture of the pars defect. Lateral x-rays are really only about 50% sensitive and specific. I like the MRI because there's no radiation and you can see the bone stress injuries early. For the test, the best tests are going to be a CT or nuclear medicine bone scan with SPECT, but there's a fair bit of radiation with the latter one. An x-ray is 3 days of radiation of being at the beach. A CT is about 10 days. And a nuclear medicine bone scan with SPECT is 23 months of laying on a beach. So if you look at that versus an MRI, I think that the MRIs are study of choice. A lot of times you have to correct the caloric deficit here. Back bracing is pretty popular on the West Coast, maybe less so on the East. You can have surgery for this, but most people actually, interestingly, even if they don't heal, do well. We won't talk about this type of injury too much because Dr. Jason Puttist, who's the medical director for the Charles Street 12-mile race and a runner himself, really gives a great talk about this later in the year. Medial malleolus, really another high-risk stress fracture area. If you think about the integrity of the tibio-talar joint, the medial side is much more important. Sometimes you'll actually miss these on x-rays. I think that MRI, again, no radiation, can see this nicely if it's a bone stress injury. But I think if you have some trauma, you definitely want to get a CT. This is a critical portion of this joint. And making them non-weight bearing in a boot immediately is the way we go until we hear from our orthopedist on this one. If it's displaced, I think you're looking at getting some sort of fixation with a screw for surgery. I have seen non-operative cares work for this, but usually it's one of those things you want to make sure that everyone's in agreement that's the best choice. Talus stress fractures, for those who recall, the reason this is a higher risk stress fracture is the blood supply. It goes retrograde through the neck. And so if you get the stress fracture that completes, you can disrupts the blood supply and get AVN to the body of the talus, which can be problematic. You'll see this injury more in basketball players, gymnasts, runners. And they usually have a very specific tender spot just inferior to the tibialis anterior tendon medially when you're doing your physical exam. When that's tender, usually I'll make them non-weight bearing and tell them until I see that MRI, we're not going to put any weight on this. Navicular stress fractures, so remember not the navicular of the wrist, which is called the scaphoid, but the navicular of the foot also has a very distinctive blood supply coming from the outside and then coming in. And so interestingly, the other species that has this blood supply is the dog species, the greyhound. And these both, with humans and in the case of the ground, running is a risk factor. Probably repetitive load with that watershed zone is why this happens. I really feel like x-rays don't see these until it's too late. MRI can even be diagnostic, but frankly, if I'm concerned, the CT is probably the best test. If you have a type 1, you probably are going to be able to do maybe some non-weight bearing for about 2 months. But anything like a type 2 or type 3, we're talking to our foot and ankle surgeons about this. We do not want to mess around. So the base of the second metatarsal and a lesser extent third and fourth, considered high risk. We see this a lot with our ballerinas who are on point. X-rays generally aren't going to be helpful. MRI is much better. But certainly when they're tender to palpation, we should be very concerned about this. A lot of times I've had short-term boot immobilization be successful, but we have to watch for non-union in these cases. Again, a watershed zone puts it at high risk. For the last one, I also think if you are looking at kids, you want to make sure you're not thinking of other things like Kindbach's or Freiberg's. These are other injuries that aren't truly stress fractures, but they're more overuse in pediatric patients. Proximal fifth met, we won't talk too much about that one. Dr. Wisbeck speaks very well on it, but zone 2, going to be something you're going to talk to a surgeon about. Most likely sesamoid stress fractures, super common again in our cutting athletes, basketball, lacrosse, dance. Really x-raying both sides, super helpful because many times you'll see actually there's a bipartite sesamoid. And you can rest in the boot for a few weeks, but the slow healing nature of this one, you got to be careful. Removing one of the sesamoids is sometimes an option. And just make sure you haven't thought of other things. This could be an older person who enjoys purine-rich foods, could be gout, turf toe you don't want to miss, plantar plate injuries. So when you look at the low risk and the high risk, how do we make sure we just don't have people again and again and again have recurrence of stress fracture? Make sure you're screening for REDS or the triad. Make sure your athlete is getting enough calcium and vitamin D. And if you have a chance to do video gait analysis for running, look at biomechanical factors and make sure they have enough sleep. US Army did a study having 3 groups of people. One got regular sleep of about 7 hours. One could sleep, but they had to be standing up. I don't know how that worked, but that was the study. And the third group actually got a very minimal amount of sleep. And the minimal sleep group almost lost 2/3 of their bone density over 6 weeks. And there was not as much, but similar loss in the people who slept standing up. So adequate sleep really is important for bone health. And that's why you tell your athletes to get off their social media and their phones and get sleep. Or if they're straight A students, that we do need to have time where they're resting. So calcium, vitamin D, sometimes a little bit difficult. It is true vegetarian and vegan diets do raise your risk a little bit for stress fractures. Although they're super healthy, avoiding hypertension and other concerns. You want to make sure calcium about 1,500 a day and vitamin D 800 a day. This may change individually, especially in postmenopausal women where calcific clogging of the arteries is a concern. But in general, we want to make sure people are getting enough. One study that I always like to point out here is just one additional glass of skim milk almost cut the risk of having a fracture by 2/3. And then if you didn't get enough of the vitamin D and calcium, you had a 6 times higher rate of stress fracture. For those of you who remember your histopathology from gastroenterology, this is a G cell on the right. I point this out because many people have esophagitis, gastritis, heartburn, and they take PPIs. These PPIs lower the acid level. They raise the pH in the stomach. And the problem with that is it changes the absorption. And so sometimes you cannot absorb your iron, your calcium, etc. So people with chronic problems, intrinsic issues of the GI gut, you should make sure their medicine list is evaluated. Interestingly, if you do something other than one sport at all times and you avoid subspecialization, those people who played basketball had less bone stress injuries later in life when they did running. And so it's just another reason to avoid early subspecialization in your sports. Touching briefly on some of the more advanced things that are out there, and these are usually not FDA approved, or if they are, they're newer. Terapeptide is sometimes known as Forteo, or its competitors, Tymlos, essentially are things that have been used by professional athletes, Division I athletes, and it basically is going to increase the effect of the chemical PTH in the body. It's an injection. You have to give it to yourself daily for about 6 months. Cost is a concern. It's about $4,000 a month. And you have to do laboratory testing at baseline and throughout the treatment. There is the hypothetical risk of osteosarcoma that has been seen in rats. However, we've never seen it in humans, and it has been successful in some people with recurrent stress fractures. Bone stimulators, very popular for long bones with non-union. You're going to see these typically for people who don't want surgery or are not surgical candidates for long bone fractures that have gone on for 12 weeks of failed treatment, and your insurance companies usually don't pay for this. There may be a component of the athlete being able to do something, because when you just tell them to sit around in a boot, they don't feel like they're really doing much. Wearing this for 20 minutes a day can be like something that helps them. And I think it's important to realize that when we take our athletes out of the sport, which they identify themselves as a basketball player, as a baseball player, you're changing their identity, and you may cause some distress. Do not minimize the fact that they may need, with a stress fracture, health psychology or even a sports psychiatrist to work through the fact they can't be with their team or do their sport for many, many weeks. So, also newer, extracorporeal shockwave. I think that this is a new thing that's out there. It very well may have some data coming out. I believe it's thought to increase blood flow. I think it would hurt to do shockwave therapy on a stress fracture myself, but my general sense is this is being done out there, and there's some early data. I don't think it's high quality yet, but you'll see people are advertising this in our community for this condition. The bottom line is stress fractures and bone stress injuries, you're going to see them. You got to know how to address them and know which ones are high risk, which are going to require you to work closely with an orthopedist. And I think that you can definitely handle, as a sports doctor, ATC, PT, as part of a multidisciplinary team, low-risk stress fractures. I want to thank everybody for joining me, and if you have anything else, don't hesitate to add comments. We look forward to seeing you soon.